all join us for a wonderful webinar that we have planned for you. And our topic today is navigating access to pain and symptom management for children with rare diseases. It's something that we see at times and we don't know the struggles, and we are actually honored and privileged to have some esteemed speakers. You will see that we have Kelly, who is the CEO of Rare Diseases South Africa, who will be highlighting us with some of the challenges. And we have a mum as well, where we will introduce her shortly. Just some points that I'd like for you to go through with you so that we have some housekeeping as well. Tracy, next slide. So yes, Busi will be introducing our speakers, as we said. Housekeeping, I mentioned, we're going to mute our microphones. Everybody, please, I encourage you to do that. It can be quite disturbing when the presenter is speaking and there are people talking in the background. Please, you can introduce yourself in the chat. We'd love to know who you are, where you're from, and your profession. And cameras on if possible. If you can't, we understand. If you have any questions or any insights or any stories that you'd like to share with us, please post them in the chat and then we will address them during the Q&A at the end of the presentation. Self-care is very important. If you need to wake up, stretch, take a deep breath, make yourself a cup of coffee, we encourage that you do so. And please respect the privacy of something personal if shared on this group as well. And at the end of our presentation, we have an online survey and the link will be added to the chat. We'd really appreciate that if you'd please do the online survey to give us some feedback, as we want to improve our webinars and we want to know what can be changed and what are your ideas and your thoughts as well. So thank you very much. I will like to hand over to my colleague, Busi Nkosi, who is now going to introduce our speakers to you.
Thank you very much, Sam, for this opportunity to introduce Kelly. Kelly du Plessis is a wife and mother of 2 children, and she's the CEO and founder of Rare Diseases South Africa, which is a registered NPO. Rare Diseases South Africa was born out of necessity when her oldest child, Juan, was diagnosed with Pompe disease at 11 months old. Pompe disease is a rare neuromuscular disorder which is fatal if left untreated. At the time, treatment for these rare conditions was not available in South Africa, and so Kelly's personal journey of patient advocacy started. Having dedicated her life and career to furthering the plight of those impacted by rare diseases in developing countries, Kelly serves on various boards and committees which focus on improving the quality of life for rare patients. In 8 years, Kelly has taken rare disease policy and patient advocacy to new heights in South Africa and has presented at various national and international conferences to raise awareness and create a new narrative in terms of treatment and access for rare patients. Understanding the isolation and lack of support surrounding a rare disease diagnosis, providing a safe place for patients as well as families, and improving patient-centered care has become her passion. There are over 6,500 patients and families impacted by rare diseases, and Kelly has assisted these individuals and ensured that patients' voices are not forgotten. Kelly was awarded the African Leadership Award for Healthcare in December 2016 in Mauritius, with other recent achievements including the winner of the Best Patient-Led Health Advocacy Group by Healthcare and Pharmaceutical Awards, the successful launch of RareX, which was the first rare disease conference in Africa, founding africarare.org, as well as the implementation of International Rare Disease Day in South Africa. The public awareness campaign reached over 17 million South Africans in 2014.
Thanks, Busi.
Future plans include further development of africarare.org across the continent, as well as the development and implementation of a multidisciplinary center of excellence for rare conditions And ladies and gentlemen, I present to you Mrs. Kelly du Plessis. Thank you.
Shame. Thank you very, very much, Bussy. It's always the most awkward thing when someone reads out your bio. But thank you so much. And I'm so honored to be here this evening presenting to you. Just in terms of disclosures, I've come out of a 2-day meeting with the National Health Department. My brain has officially gone somewhere to take a rest. So if I sound like if I'm stumbling, etc., please just forgive me. Literally, they have sucked out every bit of brain capacity I had over the last 2 days. So this little face that you see on the screen is my son that Bussy referred to. He was diagnosed with a rare neuromuscular condition at 11 months old. He doesn't look anything like that now. Now he's like a fully grown man. He's 16. Smells terrible 90% of the time, and is a typical teenage boy who does everything that teenage boys should do. And that is really only a result of the fact that he has managed to get access to the treatment that he needed, which has essentially kept him alive all these years. However, being a standard 16-year-old, getting photos of these evasive creatures is quite something. Hence me referring back to the videos and the pictures of him when he was a lot smaller. So that is my son, John. And I'm first going to start about, the notion of palliative care. And I think it's imperative that people working in palliative care understand how it is perceived by people of the public, right? So when the idea or the notion of palliative care was first brought up with me, I thought like hospice. That's the first thing that comes to mind. It must be end of life. You must be close to death. It must be that you're in, copious amounts of pain and end of life care. That was my perception. And the issue with the rare disease patients is we're not always at that stage. So we're not there yet. We're generally quite acute, but not necessarily at that point. But essentially, what should palliative care feel like? It should feel like help and support. It should feel like love, compassion, care, gentle, all of those great things. So if we look at the WHO definition, World Health Organization definition, essentially speaking, and I'm sorry for this, if everything's wobbling, it's because my family's just come home and my dog is going absolutely ballistic. Lola, please. Right, so palliative care is essentially, this is the definition, an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness through prevention and relief of suffering, But that in itself, that definition sounds cold and uninviting. So I went and I looked at the words that are used and found alternative ways to phrase them. So if you substitute these words, approach, improves, qualities, and prevention, relief, etc., and you substituted them with more loving terms, we would get a definition that moves from what I just read to palliative care being a way of dealing with the situation. I'm trying to minimize this little thing, sorry. Palliative care is a way of dealing with the situation that, why won't it work? There we go. That increases or betters the standards of life of patients jointly with their families through stopping of and the alleviation of pain and discomfort. Now that in itself just sounds a lot more loving, a lot more friendly. And the reason I mention this is because when engaging with families around palliative care,
Waar sit mens die klank harder van 'n laptop?
Sorry, I'm not sure if that was aimed
Could you
at
mute
me.
everybody, please?
Sorry, ma'am, can you please be muted?
Sorry about
Thank
that,
you.
folks. So palliative care, essentially, if you're engaging with individuals and they have this perception that it's so obtrusive almost, it kind of leads to why the discussions around palliative care can be so difficult sometimes. So that is why I mentioned this, is specifically to just try find an alternative way of framing it. But when we're now discussing bridging the gap, and this is often in the rare disease space, as I said earlier, we're not always necessarily we kind of come in at a very, very strange place before they get a diagnosis. You've got other patients that are a lot further down the journey who are really symptomatic and, very, very often quite ill from an acute perspective. So we have a whole diagnostic kind of odyssey, and there's various barriers to accessing appropriate care. So we've kind of split the patient journey up into a variety of different kind of sections. So you have the symptom phase, and that's obviously the presentation of symptoms. Now, in the rare disease space, this could be something that happens immediately at birth, or it could take, up to 6 years. 60 years, 6 decades of life before you start developing symptoms. Then you've got your diagnostic phase, and that's generally when there's a high level of suspicion that something's not right. You are feeling very, very symptomatic, and now there is this real active process of trying to identify what the root cause is. But for the average rare disease patient, that process in itself takes 7 years. Then you've got the acute phase, and this is where there is this immediate rush of support and help, and you are trying to now initiate treatments, bring in new therapies, provide the necessary support. And then you go into this difficult phase of living. And it's living beyond that acute phase. It's living beyond the diagnosis. It's living beyond the symptoms. And often this section of the patient's journey is one of the most difficult. And it's because of the fact that you're no longer acutely sick, but you're no longer overly symptomatic a lot of the time because of the fact that interventions have been introduced. But you're also not getting better, because the reality is that 85% of our conditions are genetic. So it's not like they're going to go away. The treatments and the interventions are not curative. So patients land up in this really, really tough space of not getting better, but also not getting worse. And the people that are initially supporting you, etc., kind of go back to their, to their day-to-day routine. So your support starts to dwindle. And that's honestly when it becomes very often the most challenging. There's also different barriers in terms of symptoms. You've got bias based on culture, race, age. There's fear, there's lack of awareness, there's myths and ignorance, and those all become problematic. Then in the diagnostic phase, there's issues like what testing is available, what is the doctor's knowledge and awareness about the condition. We have a lack of referral systems, financial constraints, logistic limitations. In the acute phase,
So clear than it made a big difference.
Sorry, colleagues, you guys, some of you are interrupting the speakers. Can you mute? Can I have everybody unmute besides the speakers, please? Thank you.
Thanks very much, Sam. So then in the acute phase, you move into issues around, again, doctors' knowledge and awareness, economic climate, the difference between funding decisions between state and private, the lack of treatment options, unregistered medications, all of those things. And then you move into that space of living beyond, where compliance, patient education, fear, economic challenges, all of those become imperative. So, we have symptoms that are often vague, mimic chronic common health conditions. They can be aggressive, or they can take years to manifest. The symptoms are generally not life-threatening. They only accumulate into an overall condition, which then becomes life-threatening. So it becomes quite a challenge. Then the diagnostic phase, as I said, is often stagnated care. There's a lack of diagnostic facilities, etc. And if you don't have a confirmed diagnosis and you have no ICD-10 code, that results in no funding. And I think that this becomes an imperative part of the discussion that we'll be having tonight. In terms of the cost of treatments, there's often a funding struggle. You've got a lack of benefits. You've got treatments that are not available locally. You've got clinical trials that are strictly regulated. You're using off-label medication. So that becomes imperative. And then, as I was saying earlier about this phase of living beyond, you've got an increased life expectancy. So you're kind of defying the odds, but you still have reduced mortality. You're no longer acutely ill. And all of that takes an emotional toll. So the question here is, how long is this race? And the challenge is none of us know. Often in the rare disease space, we don't get timelines. You've got to ask yourself, what happens to family members, siblings? How do they handle the stress? We have a high divorce rate within the rare disease community. We have obviously financial constraints where there are treatments available. They are incredibly expensive. Depression, anxiety, those things become quite imperative. And this was a post that I put up years ago. And you know, it's always been an interesting thing for me that there's such a stigma around taking antidepressants. I mean, I bounce into the pharmacy to get mine because I know they keep me completely sane and, you know, stop me from wanting to assault people on a day-to-day basis, and they help my general state of mind. But there is still such a stigma around being treated for anxiety and depression, and that I think, you know, could be a whole conversation on its own. So how do we now bridge this gap? Because as rare disease patients, we're moving forward. But essentially, is that the problem? Pain management doesn't automatically spring to mind because these patients are getting better. It doesn't mean that their pain is necessarily going away. What it means is because of the fact that you're treating all the alternative symptoms and they're no longer acutely ill and they've gone from having some form of symptom management process, they are moving against the grain. So we are kind of swimming upstream, and that becomes problematic. But when we're talking about access, and access in the rare disease space is really, really difficult. So as discussed, we had the issue around ICD-10 codes. If you don't have a confirmed diagnosis that's been backed up by a confirmatory test or a gold standard test, chances of you getting access to any form of treatment and intervention is imperative. And it is virtually impossible to do it in the private sector without an ICD-10. In the government sector, the issue is that no one tracks the symptoms back to the root cause. So if we ask a public hospital, you know, what are your interventions for patients with lupus? The information doesn't pull together because it's not being tracked on an ICD-10 code. So on the one side, the ICD-10 code kind of limits you in terms of what you can access. And in the public sector, the lack of use of an ICD-10 code limits your information and access of data and how you pull everything together. But then also, when you're speaking about access, you've got to understand that, you know, we do have things like the essential medicine lists. And I know that the fact that it's on a list somewhere doesn't necessarily mean it's immediately available. But those guidelines form an imperative part of the decision-making process. It's imperative to remember that when we're dealing in the pediatric space as well, you are dealing with children, and children have more rights than what adults do because you've got the child rights to health, you've got the Child Care Act, you've got the Children's Act. All of those things are imperative, and I honestly strongly recommend when you find yourself in a difficult position where you are trying to access interventions for patients, particularly pediatrics, you're not coming right, throw those terms around. Your constitutional right to access health, the Children's Act, the fact that the rights of the child have to be put paramount to anything else. You know, unfortunately, we are just in that position where we are really having to drive that access, and sometimes you have to bring out the big guns in terms of legislative accountability. But also, when registered options or pediatric formulations aren't locally available, SAHPRA does provide for Section 21 in the issues of stockouts. So I'm aware of the fact that we often have issues around stock-related issues, but it's imperative to know that there are alternatives. Yes, the SAHPRA Section 21, I'm not sure if anyone on this call has had to do a Section 21 application. The process now is absolutely mind-blowing, but the juice is worth the squeeze in the long run to be able to access or expand. The only issue is obviously that you cannot seek a Section 21 if there is a registered alternative that is currently available within the country. So the issue comes down to price. A lot of the more expensive or the nuanced medications and the more innovative medications that have a high efficacy are often a little bit more expensive or sometimes a lot more expensive. And whilst it would be really nice to be able to bring in the generic versions, it's not always possible under SAHPRA, under Section 21. Also important in terms of off-label usage. Off-label usage can be approved. So in the private sector by special motivation, but it is something that is possible. So never be scared to implement issues around accessing off-label use. If it's available and you think that you've got a good clinical evidence base as to why it should be utilized for that particular patient, 100% write that motivation and try. And then it is being treated, the primary condition is a PMB, and the diagnostic treatment pair, and I'm not sure how many people are familiar with the DTPs, but if it is medical management includes a wide variety of things. Pain management should form part of that without exception. The difference is that you have to motivate for it. So it's not to say because you write a prescription that the prescription will automatically result in reimbursement. It is imperative that you follow a process whereby you actually have asked the question of the medical scheme in question to be able to get that medication. And then lastly, in the private sector, and it's so strange for me, the differences between the private sector and the public sector are so different. In the public sector, it generally comes down to availability. Is there actually morphine in the hospital? And in the private sector, is the paperwork in place to be able to get it? And it's such a dichotomy between the two sectors, and it has me scratching my head on a regular basis. But for those in the private sector, I want to say to you, if you have prescribed or you're trying to treat a complex patient with pain management, and the existing pain management or the pain management that is included in the formulary or the protocols of that particular scheme are deemed to be ineffective, they haven't worked, they're not necessarily doing what they would do, or the patient is having severe side effects, that is something called, you can invoke Regulation 15H. Regulation 15H of the Medical Schemes Act does not directly link back to PMBs. So it's not to say that the condition has to be a PMB for you to be able to follow this process. This process, the Regulation 15, involves managed healthcare. So if a scheme has put together a protocol or a formulary, and that formulary is found wanting in terms of being able to treat that particular patient, you are able to invoke Regulation 15H. And that means that the protocols must be evidence-based, and they must allow appropriate exceptions where a protocol has been deemed ineffective or would cause harm without penalty to that beneficiary, meaning that the difference in price is not the beneficiary or the patient's issue. The medical scheme has to pick up those costs. If you can show that the existing treatment that might be included in the protocol has deemed to be ineffective or would cause harm. So that is just a little bit of the rare disease space and what it looks like, but I'm really excited to hear from the mom that's joined us. I just want to show you one last thing. So this is my son's condition, and I think whilst we're all here grappling around pain, palliative care, what that looks like, how we implement it, it's imperative to say this. Patients with chronic health conditions should be offered palliative care from the very, very beginning. At the very least, you want to have discussions around end-of-life care early, so you're not making emotional decisions. You want to ensure that patients don't get to a point of intractable pain before we start treating them. You want to make sure that they've got options, that they're in touch with their spiritual side. All of those things, all the fundamental principles that come with palliative care are absolutely ingrained in those individuals. And you also want to have the time to implement them properly. So unfortunately, for whatever reason, patients are not referred to palliative care in the rare disease space as quickly and as often as we'd like. And that's something that collectively we all need to try and change. Essentially speaking, we are all palliative care advocates, and we need to really put our hands up to continuously reminding everybody within our community, not only from a patient advocacy perspective, but also from a provider perspective, of the fact that palliative care does exist and that it should be made available. What the extent of the palliative care that gets offered is obviously variable. Some patients won't need pain medication until later on. Some patients you know, you might not need to have certain discussions. But the fact is to start that process early enough so that you're not finding yourself at the end where now all of a sudden we're trying to bring in a whole bunch of new concepts. You want to have developed that relationship with your palliative care practitioner early on. You know, I've always looked, and I remember so fondly our dear Manaz, but I've always looked at Manaz coming in with her bright hair and that personality at a time that was so critically sensitive to patients. And I always used to feel so incredibly sad because she never got to be that personality to them in the fun times. And that's really something, if I could fundamentally shift something for the palliative care community as providers, that would be it. I think you all deserve to have the opportunity to be able to engage these patients in better times as well as at the end when it gets a little bit harder. So this little video here is something, and it's just a reminder to all of us to hang on until one day some form of curative treatment comes along and washes these conditions away permanently. Until then, we're all in it together, and we just have to be, you know, we just have to hold hands and do what we have to do. So thank you so much for listening to me ramble on, and I'm happy to take any questions. I'm not sure if you want to do them now or if you want to do the other speaker first before we move over to the questions. Sam, I'll hand back over to you.
Thank you so much, Kelly, for that insightful topic. It's really, really appreciative, and you've been through some hard times, and here you are, conquered everything. And thank you for also honoring our dear friend Minaz. We do miss her. I do think we should have questions and comments at the end of the session, if that's okay with you. And I'd like for us to go to our next speaker. We have an esteemed mom of a neurofibromatosis warrior. Lebohang, I hand it over to you. Please, can you introduce yourself to our speakers so they know who you are, and you can share with us your experience and your challenges. We can't wait to hear from you.
Yeah, okay, thank you so much. Hi, everybody. On social media, I always say, hello, guys. My name is Lebohang Leuta, and I'm a warrior mom. So I'm a warrior mom. I'm a mother of 3, and I am raising a 15-year-old boy, Lebohang, who was born with neurofibromatosis type 1. Now, what is neurofibromatosis? Neurofibromatosis type 1 is a rare genetic disorder that affects the growth and development of the nerve So basically what happens is that one would have, the symptoms varies, right? So one would have tumors around the body, or how you would notice that somebody has got neurofibromatosis, it's through seeing cafe loud spots. It's more like coffee spots on the body. With my son Lebohang, he mainly has tumors on the scalp, and we recently removed one on the chest. And how it has affected him is that he has a learning disability. He was diagnosed with dyslexia. So I've been a warrior mom for the past 15 years because he was diagnosed when he was only 6 months old. And it has been a very difficult journey. However, through the difficult times that we've had, I always say that special moms for special kids. We were chosen for a reason. I look at my son every time, and I'm so grateful to have him, because if it wasn't of him, I wouldn't be where I am today. On my social media platforms, I've created a safe space for parents that are raising children with rare medical conditions, recently coming up with a podcast just to create a safe space for women to heal and speak about the challenges that come with raising children with rare medical conditions. And unfortunately, with myself, I've put out our situation out on social media. We have got more than 35 followers on 35,000 followers on TikTok. So basically what we do is we advocate really about neurofibromatosis and the challenges that we've went through. And it is very unfortunate that our people are not sanitized about how to create an inclusive environment for young people or children that have medical conditions that may cause disabilities, because with him, it has caused a disability. Also, he has lost hearing on one ear due to the tumors that have closed the one ear. So a lot of parents, they would mock me about my son's condition, and it would affect me also to an extent that I would want to retaliate, which is normal. I mean, if somebody would say something about your child that's hateful, it is absolutely normal for you to want to retaliate, and it's something that I would always want to do. I had Kelly mentioned organizations that help support children's rights. Now, this is a question that I would like to ask to. This is a question that I would like to ask. To everybody in here that maybe has any information on how we can tackle such situations, because it has caused us so much stress. Not myself only, and my son as well, to an extent that he wanted to commit suicide the other time because of being mocked about his medical condition. We've tried channels like going to the police station to go open up a case, and I mean that is also exhausting. I feel like it's going to be very exhausting to my son, taking him to courts and attending courts. That can be very stressful on a 15-year-old. However, it's something that he's also willing to do. But what more else can we do besides creating awareness about rare medical conditions and actually teaching our people about the challenges that come with raising children with special needs, or how to create an inclusive environment? What can be done to make sure that we avoid such things? Raising Atlehang has come with a lot. I don't want to lie, emotionally and otherwise. There's days where I feel okay, and there's just days where I just feel overwhelmed and I just want to give up. Like recently, I posted his picture now on Facebook. I'm very sorry I didn't prepare myself enough, because I think it was going to be nicer with visuals and everything. However, I'm just going to give you an idea of what I posted the other day on Facebook. I'm very vocal about my son's condition because I want to be an inspiration to other parents that are raising children with rare medical conditions, to gain strength from myself. As much as it hasn't been easy, I've tried to make sure that I've become so as positive as possible, I mean to say. It has come with a lot of emotional roller coaster. However, like I mentioned, I have tried to become as positive as possible. And one of the things that kept us going as well is by trying to take Atlehang for therapy. He's had so many suicidal episodes or thoughts, and I've been that mom that has tried to make sure that he's healthy mentally at all times by making sure that I take him for therapy at all times. I love my son. I love my son so much. I make time for him, and I make sure that he's healthy at all times. Even though he's got a medical condition, I try, make sure that I take him for his hospital appointments and all. As it is tomorrow, we are actually going for our hospital visit to go book for surgery to remove the tumors on the scalp, because with his medical condition there is no cure at all. The only way that we can deal with it is just by removing the tumors through surgery every now and then, whenever we see that they're really getting out of control. Yeah, so should you have any questions about the medical condition itself or how we've managed to pull through, you can just keep the questions coming at the end of the meeting. Thank you.
Thank you so much, Lebohang.
Thank you.
I think always hearing it from a mom's perspective, it makes it more meaningful. Both you and Kelly have shared so much of insightful um, challenges to us, and how it has become and how it has changed your lives, and how do you go about your everyday. And people actually don't actually understand that at times. When actually speaking to patients about their challenges, it's all about the disease itself, and it's not about who you are, what you stand for. How can we help you and your family through this emotional journey, this financial journey? I see that it's been quite challenging for you and your little man. You have posed a question as to how to help him. I'm not sure if the audience has any ideas. I have some ideas of my own, which I'd like to chat with you about later on, if possible. But yeah, I'd like to see what the audience has. If there's any comments, if there's any questions, please now, this is the time to, we have two experts on our field, to ask them for help, to ask them for their wisdom and how we can make a difference, how we can change our children's lives with rare diseases, how we can improve their lives, how we can make sure that we can take away the stigma. You know, they are also children, they have feelings, they want to be part of it, they have dreams, hopes, and aspirations. And how do we make them feel included?
So, if I can, Sam, I want to say, you know, the issue of particularly symptom control and pain management on a continued basis is so difficult to like to quantify from an objective perspective, because your pain threshold but might be much higher than mine, etc., etc. A simple intervention that we've seen really works in the pediatric space is the use of emojis to determine where the patient's at, right? So even though my pain threshold might be higher than yours, I'll know that it's got me to a crying face. Like, that's the same. So we've found that by trying to engage, I think, you know, trying to engage with the patients in a way that kind of narrows down the options for them a little bit really, really has gone on to help quite a bit. And specifically in terms of understanding pain and how they feel about a certain thing. So, I mean, like Lebohang was saying, you know, her son's battled with mental health. I can say that we've had the same challenges within our household. And it becomes, you know, these are lifelong conditions, and we don't get the opportunity to take a break from them. And I think that is the downside to any chronic illness. But also, and you've heard from two strong mothers who we've just kind of jumped in and taken control of the situation. We're not going to be able to do that forever, though. Both of us are sitting with kids that are about to go into the real world and have to fend for themselves. And, you know, we need to empower them from an early age as to how to do that. So they've got to learn to be able to speak for themselves. And the sooner we start engaging them as part of the holistic kind of discussion, and giving them tools in which to be able to advocate for themselves from a young space and a young age, I think we really just create a much stronger, more empowered patient to be able to go out into the world as a young adult. I'm seeing a question that's come through from Dr. Aduk. What about support groups for adolescents and young adults with rare diseases? Do they exist? Who puts these together? I know you guys run support groups. So, Dr. Aduk, yes, we do have support groups. The one challenge that we have with the adolescent space, and maybe this is somewhere where you guys can give us some tips, is it's this tough spot around being involved and monitoring versus giving them space. So they don't necessarily they want to be able to have, what we found about adolescents is they want to actually ask things about, like, is it safe for me to have sex? Like, can I be drinking whiskey, or should I drink beer? Like, if I smoke a joint on the weekend, like, is it going to infect my health? Those are the questions that they want to ask. So they want to do it in an unmonitored space. They don't necessarily want an adult there, but at the same time, we have a responsibility to moderate those groups, to make sure that the advice and the feedback that's given and that there's no bullying, etc. So that's the one challenge that we've had. So we find our presence doesn't really help. So we'd love to go back to having in-person events for our adolescents where they can actually all be together. But what we also have found is when we've got adults, young adults, and particularly med students. So if we identify med students who are also living with chronic illness, they're like perfect for us because we can utilize them. They've got the medical knowledge, but they also have the lived experience, and we can utilize those individuals for mentors of the adolescent groups. And that really helps. So we look for young adults who have some medical knowledge, but that is the one challenge we have with the adolescent group.
Interesting, Kelly, because that's the actual things that they actually want to do. And then you have this chronic illness that is dampening everything, and they want to explore. They have own feelings and emotions.
100%.
And then, and yes,
And you can never ask because your mom's always with you, right? Lebohang and I don't
of
let our kids
course.
go anywhere without being right there. So how do you have, I mean, do you like write your doctor a note and slip it to them under when your mom's not looking type thing? And that is the stuff that's important to them. They want to live meaningful lives and make errors like any normal young adult. So it's to give them the space to be able to do that. Our pediatric neuro, she actually had like a really serious conversation with my son, and I was like, what are you doing? Because she was like, listen, I'm going to be honest with you. If you go to a party and you're drinking this, she said, if you're going to drink, stick to whiskey and water. That's going to be the much better option for you from a glucose perspective. And I kind of looked at her and I was like, don't encourage that. And she actually corrected me, and she was like, I can guarantee you he's going to try. It's my responsibility to make sure he does it in a responsible manner. That's my obligation. Yeah. So it was a bit of an eye-opener for me, and it kind of changed the way I think about this adolescent space.
I think for me, what I've learned is that you have to understand what they're going through in their own way and their own time. And with an adolescent, they're not just going to freely talk to you. You have to gain that trust. And it takes a time, it takes process, and you have to hear them and hear their concerns, their fears, and their worries. And it's very important to make them part of the team. And like your colleague has done, she's given him the opportunity to try stuff, but she's made it a responsible, safe way to do. So it's like you are acknowledging their needs, you're giving them the opportunities to do it, and you are actually including them. And many of us actually forget to do that when it comes to adolescence because we are there with our own purpose. We want to push this on them, and we don't want to include them in the decision making. And I feel that's very important.
Absolutely. Absolutely.
Does anyone have any other comments or questions for Kelly or for Lebohang?
Just another thing, actually it's a question from my end, another question. Samantha, maybe, or Kelly, anybody who can just advise. So now, and as much as you can try as a parent, to create a safe space for your child to be as comfortable as possible with you. I feel like my son, with Atlehang, it's much better to open up to his therapist than to me. And it's very unfortunate that most of the things that are said in that room, I cannot even know of. Just a moment, sorry. I'm a mom to a baby.
No worries.
That's okay. That's okay. Lebohang, I think you muted yourself. You were saying?
Sorry, yes. I was just giving somebody my little one. Sorry about that. She was sleeping.
No, it's fine. You can have her. She can join the webinar. Don't worry.
No, it's okay. Dad took her. So now, with him, it's very difficult for him to open up to me, in as much as I would really love to have those conversations of how to behave. Now that he's a teenager, he's obviously going to start doing some things, he does not open up to me at all. the only way he opens up is when he goes for therapy. And it's very unfortunate because the things that I said in that room, I don't even know of.
Lebohang, have you tried certain things like for him journaling his thoughts, his processes? I'm sure he has a phone, an iPhone where he can, or any like a phone where he can start doing YouTube videos or recording his own voices. You know, sometimes what I find with the adolescents is that when they go and look on social media, they find out that there's other people going through the exact same thing as me, and it's not the same. You know, they share their lived experience. I'm not sure if that has been tried with him. I'm sure the therapist has probably suggested all these things for him.
Samantha, it's what I'm currently encouraging. If you go
Okay.
into our social media pages, you will see he even reprimands the adults that actually attack me with his medical condition, you know. He shares as well his life experiences about how it feels like being having a rare disease. I mean to say, growing up with a rare disease. However, it's more of the teenage stuff that I'm worried about, because also, you know, he's starting to become a big boy now, and he'll be more secretive about most of the things. I don't know if you get me.
Yep,
Yeah,
I
I
get you.
get what you're saying.
Yeah, so I'm struggling to get so much from him to support him as well, because I don't know much. He doesn't even talk to me as much. So how do I
Lebohang,
now tackle?
I'm gonna say something that broke my heart to hear it. And I had a very dear friend who had walked the journey ahead of me that told me this.
Mhm.
But you can't be that person for him at this stage of his life. And it sucks because we've been the everything for him, for them up
Mhm.
until now. And like I'd like cried. I had like a loss of identity when the reality actually kicked in. But we at that phase now where you've got to start kind of letting them go to a certain extent, and they don't. The one thing I have also learned is that they don't. Our children who've grown up and they've seen the impacts of the stress that living with this has caused on us as their parents, and as a result, they don't like sharing their true feelings around certain topics with us because they feel like they're burdening us even more and they don't want to stress us out even more. And whilst we saying to them, don't be ridiculous, it's not going to happen, I think that they feel a great sense of responsibility to us, similarly to how we do to them. So that's the one element, is that level of restraint in terms of protection. And it's so sweet how your boy wants to protect you from that. And it just shows that you might feel he's pushing you away, but actually he's probably just loving you in a way that you didn't actually perceive to be love and care. And then the second element is the fact that this is them stepping into that independence where they don't need us to make all the decisions and help them with everything. And it's so hard. I just sometimes I want to just take my son and put him back in my lap and, love him like I used to when he was little, but now I can't pick him up. So I see someone has said here, it feels like it's hard to let go. And I think this is not something that's unique to us, Lebo. I want to say, I think that this is something that's unique to parents. We just feel it a lot more because we've been relied upon so much more than, we've been like the life source. And I think it's that loss of identity of being their primary caregiver to now just being a mom. Like, we don't know how to do that because we've been the primary caregiver all along. We've lost our experience as moms wasn't that of the normal mom journey where you could just
Mhm.
love your kid and do fun things. We've had to be the primary caregiver. So to step back from that role is incredibly, incredibly tough. But I'm here for you, man. Just phone, because I know exactly what it's like and I'm going through the same stuff.
Well, thank you so much, Kelly. No, I'll definitely ring you.
Thank you,
Yeah.
ladies. I see that Danielle, we have a colleague, Danielle, who also has a chronic disease. Do you want to share your experience with us, Danielle?
I did this to myself, I suppose. I wasn't going to say anything in the chat, and then Kelly was literally talking about medical students with chronic illnesses, and I was like, oh gosh, okay, I better say that there is actually one in the chat. My story is very long, and I don't actually have a set rare, or well it might be rare because it's not diagnosed, but set rare or chronic disease. But I am a final year med student at UCT, and I'm in my second final year, which is going to be my third next year, just trying to finish, because I developed a chronic migraine condition about 2 years ago, which led to progressive chronic daily headaches and photophobia, and then just escalating chronic pain syndrome, and just all spheres that you can think of, and autonomic dysfunction, and completely just transformed my life. So I've been navigating trying to finish becoming a doctor, and learning a lot about myself and seeing a lot of medical specialists, and trying to work out where my place in medicine still sits. But one of the places I'm still very passionate about is in child health, and in palliative care, and which is one of the reasons when I did my when we did family medicine and we had our one pediatrics palliative care talk, and I learned about Patch, that I subscribed to the newsletter, which is how I ended up on this webinar. So it's something I follow. So yeah, I don't have a huge amount of physical capacity, but I try to listen in, and I would definitely be willing to try and see if I could even get involved, and talk about how you guys work with young adults, and discussing symptoms. And I did some of my elective work with the Desmond Tutu Health Foundation at one of their youth centers a year or two ago in my 5th year, and that was a great experience for me, where I really saw that the difference you can make as a student mentor, and how much young people open up to you as a young person when they can relate to you as part of their kind of their age group, and how that makes a big difference. So I could imagine that having people with similar chronic illnesses from a younger perspective is also really helpful, but also such a challenge. I can see it from the sort of doctor perspective of having to be involved and give the right advice. And so I thought that was a great, story you shared about, the doctor giving actual practical advice about which alcohol to drink, because that children are going to, teenagers are what they're going to do. So actually you've got to work out how to help them be safe as possible. So anyway, sorry, I'm also rambling, my brain fog, but that's kind of my story. And thank you for everyone for sharing. Wow.
Danielle, I want
Wow,
to say thank you
Danielle.
so much for coming on and sharing that. I know it must be a big
Yes.
step for you, but I also want to say that just remind yourself that you could also be a source of inspiration to some young people thinking, it's never going to be possible for me to finish a degree, and I don't have the energy levels to do it, and my condition's going to hold me back. I think the fact that you're persevering despite everything is just such a story of strength and solidarity in itself, and I'm so grateful that you shared it, because I feel inspired.
Oh, that's very
Thank you for
kind.
sharing
Thank
that.
you. I'm
Thank
sorry
you,
my
Danielle.
video is not on it. It's because I'm in the pitch dark, as I normally live.
It's
And that's
okay.
very kind. Thank you, because I'm on leave actually till the rest of the year. So I go back next year for my last 6 weeks of medical school, which I'm hoping to finish. And then I will have the rest of the year off, where I'm hoping to actually get involved and do some of the stuff I actually enjoy. So maybe that'll mean actually getting to, you know, maybe we can get in touch and maybe even talk more about doing some work with some of the younger people, because yeah, just sounds like
Danielle,
we
you
all
can be a very true inspiration to young adults because you've been there, done that. You've been through so many challenges, and here you are, still persevering. So well done to you.
Thank you. That's very kind. Thank you so much, everyone.
Okay. We've got 1 minute to close. I don't know if there's any other comments or questions. I do want to thank our speakers for being here with us today and sharing their insightful thoughts with us and their challenges and where they've been and where they come through. It's been really great listening to you all. And I do always say listening and to a mom sharing the experience, it's actually more special because it's actually very, very true and it's from the heart. So thank you to you both. Tracy, I think you want to put, yes. So I've put in our online feedback form. There's a QR code as well. Really appreciate if you guys would please complete our online survey. Please comment, give suggestions, some thoughts on how we can make our webinars better, what topics you'd like to hear, suggestions, anything. We'd like to hear from you because that's what we want to make it. We want to make our webinars homely, where you can understand, it's down to earth, it's what you experience on a daily basis, what you want to hear. So those type of things, and we really appreciate it. And to the audience and our colleagues who have joined us from far and wide, it's really great to have you all with us, and thank you for taking the time and being here.
Thank you so much for having us. I really enjoyed it.
Thank you so much, Kelly.
Thank you so much for inviting me as well. I really enjoyed it. For the first time in my life, I enjoy a webinar. I'm actually very comfortable to speak.
Well done, Lebohang. We will remember that, because when we need to speak to a mom and have her experience, we've got you now on speed dial.
Yeah, okay. No, thank you so much.
Okay.
Shame. Thanks, everyone. Have a good
Thank you,
evening.
everybody.
Thank you, everybody. Have a wonderful evening.
Everyone.
Take
Thank
care.
you,
Bye.
everyone. Bye.
Thank you.
Thank you. Bye-bye.
Bye.